Yolande, can you hear me?
I can, thank you.
Thank you. Hello, Chuck or Carol. This is Kim. Are you guys logged into the call?
Okay,
Now can you hear us?
Yes, you just.
Yes, I can hear you guys.
Kim, can you off of mute?
1 second.
Still retaining also?
Yeah, so both of you, Chuck and Kimberly, are now hosts.
Well, no, not now.
Now it's Chuck.
Gotta go to your name.
Marjorie, do you have the old numbers to the public?
No. You have it. Wait a minute, let me find your name. So many people logged in.
I have it.
Oh, okay. All right.
Okay. Thank you.
You're welcome. Bye-bye.
Hi, good morning. This is the Centers for Medicare and Medicaid Services. This is the hospital outpatient payment and advisory panel meeting. For those that can hear us, we will be going live about 9:30. We're having some technical difficulties, so please remain on the line. And if you email the APC panel at cms.hhs.gov, you will receive an updated info for access for those that are on the phone who are having difficulty getting in
To the webinar.
Otherwise, for those that can hear me, please remain on the line. We think we'll be able to get started about 9:30 when we work out these technical difficulties. Very much. We'll be back at 9:30.
Hi, this is Kim, the moderator. I've unmuted all the presenters and the panel members' lines. If you have to step away, please mute your phone lines back to avoid any kind of background interference. Thank you.
Kim, can you hear me?
Yeah.
This is Carol Schwartz. You had the list of presenters and the list of panel members. Do you know who is still missing?
Yes, I do.
I'm sorry, what?
Yes, I do.
Can you advise me, and I'll see, and we can work on those people?
I don't see Agatha. Rick. Last name is Nordal. And that was Scott Manicry.
You don't have him either?
No, I don't know, but I'll go back through the list.
Scott is on the line. I can hear him chiming in.
And
okay.
Shelley Dunham.
I thought you were just checking to see if I'm paying attention or not.
Okay.
That's you,
okay,
Scott.
Scott. Thank you. My
So
apologies.
So we're missing Nolan and Nordal?
Yes, and
Rick
Ken.
is here. I just stepped out for a minute.
Oh, okay.
Rick Nordal is here.
Nick. Oh, thank you, Rick. And Agatha, are you there? And do I have Ken Flower?
Ken Flo. Actually,
Ken
I sent you an email about him. He needs some assistance.
Okay, I'll check my email.
Okay.
And what about the public speakers that I gave you a short list on them? Can you advise me who you think is missing?
I don't have Michael Beebe and DeShane Dorsey.
DeShane Dorsey thought he was, I sent you an email.
DeShane Dorsey, she's lit up, but I don't see a phone by her in your participants, and I don't see, any other designation, but her name is here.
Okay.
And actually, she thinks she's in. So maybe you want to check on DeShane Dorsey, but you don't have Beebe, huh?
No. And I don't have Gary Gibbons. And I think I have Eric Gregg. I did see him on there earlier. I have to double check.
If you could check with Eric Gregg and have him work with you on Gibbons.
Okay.
Or is it Phoebe?
Is she a speaker? Is Donna also a speaker?
Oh, she's going to need a phone.
But is she a speaker?
Yeah.
Okay, so Donna Oso has an X with the headphones. I don't know what that...
Donna Oso. I'm talking to Shane Dorsey. Needs a speaker.
Understood, but I asked you about Oso.
Okay, I thought you were pointing to
DeShane Dorsey needs to be able to speak, so I'm asking you a question. Is Donna Oso one of our speakers?
I don't know who she is.
Oh,
yes, I see Donna on there. Donna, if you can hear me, because you're on the speaker, you dialed in through the computer, you will not be able to speak. So Donna, Donna, what you need to do is unplug. I'm sorry, go ahead.
Donna Oso does not need to be able to speak, but DeShane Dorsey does need to be able to speak.
Okay. So anyone that is logged on through the computer that needs to speak, because I see Ken on here as well, you need to disconnect from the computer and hit the button that says dial in through the audio, dial the 844 number, 396-8222, the meeting ID, and the attendee ID, so you can get into the call so I can unmute your line. So that's
Kim?
all the ones that are on the computer.
Kim?
Yes.
Kim?
Yes.
We have a problem with DeShane Dorsey, who says that they can hear all that we're saying, but you cannot hear them. So maybe you want to check on the status of that one.
Okay. So, DeShane, give me a call on my personal line, and that's 410-786-2031. Again, 410-786-2031. And all others that are on the computer, you need to disconnect from the computer and choose the option for the audio, or you can also give me a call on the 410-786-2031. 2031, and I'll walk you through it. And right there on the screen is also how you dial in with the 844-396-8222. There is the meeting ID. And you can also hit pound for the attendee ID. Okay, thank you. I'll return in a second. Cheney, can you hear me?
Yes,
Okay, I'll leave your phone line unmuted.
thank you.
Thanks.
Do we have Ken Flo on yet?
I'm still working through the list. I see that Ken is there, but Ken has dialed in through the computer. Ken, if you can hear me, can you call my personal line? Can you call me on 410-786-2031? Again, that's 410-786-2031. Thank you. This is Kim. Ken will be dialed in momentarily. Thank you.
Kim, hold on a sec.
Yes.
Chuck says,
Hey, Kim, could you take a look at the chat that I just sent you about a technical issue with WebEx, please? Thank you.
Kim?
Okay. Yeah.
Can you call Jonathan Pregler? He got your voicemail.
Okay.
It's 310-267-8273.
okay, Kim, I'm about to go live with this meeting. Is there any impediment to me doing so? All right, everybody, we're fixing to go live with the meeting.
And Kim, before she goes live, I will be emailing you issues, so be looking through your email. Okay?
All right. We done?
We're done.
All right. Good morning, everyone. My name is Edith Hambrick, and I'm the chairperson of the Hospital Outpatient Payment Advisory Panel meeting. I would like to extend the Hardy Centers for Medicare and Medicaid Services welcome to the first 2016 meeting of the Advisory Panel on Hospital Outpatient Payment. I'd like to first let the panel members introduce themselves, tell you a little bit about where they're from, and then I will continue on with the meeting. So if we could start off with Ms. Shelley Dunham. If you could introduce yourself.
Yes, my name is Shelley Dunham, and I'm the CEO of a small critical access hospital in Okeen, Oklahoma.
Thank you, Ms. Dunham. Ken Flo. If for some reason you can't speak, we'll come back to you. We are having some technical difficulties, as you know, by the fact that we started about a half an hour late. Dawn Francis.
Hi, I'm a practicing gastroenterologist at Mayo Clinic in Jacksonville, Florida.
Thank you, Dr. Francis. Erica Hardy.
Hello, this is Erica Hardy. I'm a coding manager for a health system in Louisiana.
Thank you, Ms. Hardy. Karen Lambert.
Good morning. I'm a president of Advocate Good Shepherd Hospital in the northwest side of Chicago, part of the Advocate Healthcare System.
Thank you, Ms. Lambert. Ruth Londay.
Hello, my name's Ruth Londay. I'm the Senior Vice President for Patient Care Revenues at Memorial Sloan Kettering Cancer Center in New York.
Thank you, Ms. Londay. Scott Maneker.
Hi, I'm a practicing pulmonary and critical care physician at the University of Pennsylvania in Philadelphia, where I'm also vice chair of the Department of Medicine.
You're a little weak there, Dr. Maneker. I don't know if it's the phone connection. We can hear you, but it's a little bit weaker than the other people. Thank you, though.
Okay. Do you need me to repeat?
Maybe not. I don't know what that's all about.
Hello, this is Ken Flo. I'm fine.
So if you're on, maybe someone said it might be speakerphone. So why don't you mute? Thank you. Ooh, okay. Agatha Nolan.
Yes, thanks, Edith. I'm Agatha Nolan. I'm a pharmacist, and I have a doctorate in U.S. health policy, and I work in our regulatory compliance support group for the corporate office for HCA in Nashville.
Thank you, Dr. Nolan. Rick Nordahl. Send an email about him.
Yep.
We'll come back to you, Rick. Jonathan Pregler. So we'll come back to you, Dr. Pregler. Michael Rabowski. We'll come back to you, Dr. Rabowski. Wendy Resnick. Resnick, can you hear us now? Can you respond? Okay, we'll come back to you, Ms. Resnick. Michael Schroyer.
Was Wendy on? I'm sorry.
She didn't respond. We'll come back to you, Mr. Schroyer. Norm Thompson. One of the ones that have question marks.
Okay, try Ken Flo again. He thinks he's on.
Okay, we'll come back to you, Dr. Thompson. Chris Zimmer. Okay, we'll come back to you, Mr. Zimmer. How about Ken Flo? Are you with us now?
I think I'm on. Can you hear me?
Yes, we can.
Yay.
So, Nordahl.
Wait. Okay. Go ahead, introduce yourself, Dr.
This is Rick Nordahl, Sanford Sheldon. I'm the chief executive here. Small critical access hospital in Northwest Iowa.
So that's Rick. Thank you, Mr. Nordahl. How about you, Dr. Flo? Could you tell us a little bit about yourself?
Good morning. I'm Ken Flo. I'm an emergency physician and the chief medical officer at Rice Memorial Hospital in Wilmer, Minnesota. We're a regional referral center, but out here in the country, that doesn't mean we're very big. We have a couple of hundred docs that work with us in varying capacities and pretty much of a full-service small community hospital.
Thank you very much.
I'm the chief medical officer, if I didn't mention that. Yeah.
Thank you, Dr. Flo. And I'm going to go back to ones that we couldn't pick up before. That would be Jonathan Pregler. Can you hear us?
Yes, can you hear me now?
Yes, we can.
Very good. This is Dr. Pregler. I'm the Director of Operative Services at UCLA, and I'm an anesthesiologist.
Thank you, Dr. Pregler. Wendy Resnick.
Hi, can you hear me now?
Yes, we can.
This is Wendy Resnick. I'm Senior Director of Finance at UF Health Shands Hospital in Gainesville, Florida.
Thank you, Ms. Resnick. Michael Schroyer, can you hear us now?
Yeah, can you hear me?
Yes, we can.
Great. Yeah, I'm Mike Schroyer. I'm the president of the Northeast region for St. Vincent Health in Indiana.
Thank you very much, Mr. Schroyer. Norm Thompson. Norm Thompson. Oh. Okay. Chris Zimmer. Okay, so.
Michael Robosky.
Yeah, I got Robosky. Dr. Robosky, are you on? I think we spoke, right? Maybe not. So those three. Okay. So, thank you, everyone, for joining. We have a quorum, so we'll go forward. And if those who we've called who aren't able to speak, please email Carol so we can try to get you on so you'll be able to speak and vote, obviously. And keep us updated as to what's your status. Joining us now is Mark Hartstein, the Director of the Hospital and Ambulatory Policy Group, who will give us some opening remarks.
Good morning to everybody who's joining us today, and if you're joining us on the West Coast, good early morning. And if there's anybody in Hawaii, I'm glad you're awake. So I just want to say thank you to everybody who's attending this meeting to discuss issues related to the Hospital Outpatient Prospective Payment System, better known as the OPPS. As always, we appreciate the panel's expertise and we value your contributions to improve CMS policy by strengthening the connection between Medicare payments and high quality and efficient care. In a little while, Dr. John McInnes, Director of the Division of Outpatient Care, he's going to provide an overview of the 2016 OPPS and ASC final rule, which was published in the Federal Register this past November. And now I'm going to say a few words about the hospital outpatient panel. So CMS has long recognized the importance of the public's role in developing effective policies. including assistance of advisory panels such as this one. I have been out talking to people, and I always say that I appreciate all of the input that we get from external parties, whether it be through an advisory panel, whether it be through public comments or meetings with individual groups. CMS very much appreciates all of the expertise and thoughtfulness that people provide when they provide us with comments on our policies. Advisory committees ensure that the public involvement and expert advice are part of the federal policy-making process. The hospital outpatient panel specifically is charged with advising the Secretary of Health and Human Services and the administrator of CMS regarding the clinical integrity of ambulatory payment groups as well as their associated weights. These are the fundamental components of the OPPS that have a significant effect on CMS's ability to make payments that support high quality and efficient care. This is the 28th meeting of the hospital outpatient panel since its inception in 2001, and the panel continues to provide CMS with valuable support and assistance. This is a very long-standing panel, having been around for 15 years, and we appreciate all of the valuable time, support, and assistance that have come to us through the many people that have volunteered their time to participate on the hospital outpatient panel. So as I do each time I address the group, if applicable, I always like to welcome our new panel members. I much prefer to do that face-to-face. Obviously, today is a phone and WebEx meeting, so I won't be able to see your face when I call your name. But since even though you're at your desk or in a conference room somewhere, please, when I say your name, just acknowledge me saying your name by just waving. Next time that we have an in-person meeting, I will do the acknowledgement again and welcoming of our new panel members because I do want to make a face-to-face contact. So Shelley Dunham is the CEO of O'Keene Municipal Hospital in Oklahoma. Thank you, Shelley, for joining us. Ken Flo, MD, is the Chief Medical Officer at Rice Memorial Hospital in Minnesota. Thanks, Ken, for joining us. I have lived in the past in Minnesota. I went to graduate school there for 2 years in Minneapolis at the Humphrey Institute of Public Affairs, so I have fond recollections of my time in Minnesota. Erica Hardy, Systems Coding Manager for Franciscan Missionaries of Our Lady Health System in Louisiana. Thank you, Erica, for joining us. Karen Lambert, who's the president of Advocate Good Shepherd Hospital in Illinois. And Dr. Scott Maneker, who is rejoining the panel. He had a previous time on the panel. He's the vice chair for regulatory affairs at the Hospital of the University of Pennsylvania, and I had the pleasure of seeing Scott last week at a different meeting. Scott is very involved in public policy issues on many different fronts, and so we appreciate having the benefit of his expertise once again on the hospital outpatient panel. Agatha Nolan, Director of Regulatory Compliance Support for HCA. Thank you, Agatha, for joining us. Rick Nordahl, CEO of Sanford Sheldon Medical Center in Iowa. And thank you, Rick, for joining us. And to all of the panel members, again, we sincerely appreciate your invaluable contributions of professional expertise and experiences to this public process behind the CMA payment systems. And I will turn it back over to Edith, who will go into our regular agenda.
Thank you, Mark, and we look forward to seeing you face-to-face with our new panel members in the late summer, potentially.
All right, very good.
Thanks a lot. Okay, I'm going to skip over some of the, in view of the fact that we started a little late, but as Mark mentioned, the hospital outpatient final rule was published in November, specifically November 13th. The comment period closed December 29th, so I'm sure we have your comments already. The final rule for the Medicare physician fee schedule was published in the Federal Register on November 16th, and the comment period closed December 29th. And for those that are keeping track, the final rule for the hospital inpatient for fiscal year 2016 was published August 17th. I want to draw your attention to the charter, which is in the attachments on the web, and I'm going to, this is Edith Hambrick again, I'm going to read what the panel's charge is. The panel shall advise the Secretary and Administrator of CMS about the clinical integrity of the APC groups and their associated weights. The panel is technical in nature, and it will deal with such issues as addressing whether procedures are similar both clinically and in terms of resource use, assigning new CPT codes to APCs, reassigning codes to different APCs, reconfiguring the APCs into new APCs, evaluating the required level of supervision for hospital outpatient services, although we don't have that particular chart this meeting. The subject matter is limited to these and related topics. Unrelated topics are not subjects for discussion. Unrelated topics include, but are not limited to, the conversion factor, charge compression, pass-through payments for medical devices and drugs, wage adjustments, the types of practitioners who are permitted to supervise outpatient services, and the like. A copy of the charter is available on the website with today's materials. The panel will hear presentations and comments primarily related to the calendar year 2016 final rule. Comments that are not primarily related to the rule may be ruled out of order. I'd like to walk you through the what we call the 2 times rule. Section 1833 T2 of the Social Security Act provides that, subject to certain exceptions, the items and services within an APC group cannot be considered comparable with respect to the use of resources if the mean cost for an item or service in the group is more than 2 times greater than the lowest mean cost for the item or service within the same group. We use the mean cost of the item or service in implementing this provision. The statute authorizes the Secretary to make exceptions to the 2 times rule in unusual cases such as low-volume items and services. In the supporting documentation, the 3rd attachment, you will find the 2 times rule. If you turn to page 1, at the bottom of the page, APC 5012, it actually flows over to page 2. You will see an example where there's no violation. If you look at that page, the lowest mean cost is G0249, which is $100.77. Okay, mine is slightly different. So if you also look at the bottom of page 1 or on page 2, depending on how your document's paginated, 99496 is the highest significant procedure in that APC, and that's $161.04. Thus, the 2 times rule has not been violated. If you look up at APC 5011, which is one above that, still on page 1, you'll see the lowest significant procedure is 99490, which has a geometric mean cost of $29.36. The highest paying service in that is G0101, which has a mean cost of $60.09. So technically a 2 times violation, but obviously not by much. So that's how the 2 times rule works. Lastly, oral presentations should not exceed 5 minutes in length for an individual or organization. The chair may further limit time allowed for presentations due to the number of oral presentations if necessary. In addition to formal oral presentations, there will be an opportunity during the meeting for public oral comments limited to 1 minute for each individual or a total of 3 minutes per organization. Please queue up for that, as when I finish speaking, Kim will tell you how to do that. When you speak, clearly identify yourself and your organization if applicable before speaking. That also includes all panel members and CMS staff if you are called upon to speak. So, Kim, could you let everybody know how they would be able to make a comment?
If you would like to ask a question, please raise your hand in the chat.
Okay. Would there be a way for them to ask verbally? Sometimes we have star, whatever it is, star 3, 5, 7, whatever. Or is it just going to be via the chat?
Just via the chat. We no longer have the #5 anymore. And for all the callers that are already unmuted, the lines are unmuted. So if you have a question, you can certainly ask a question. And right now, I don't see any hands raised to ask a question.
Thank you, Kimberly. Next on the agenda, Dr. John McGinnis will give us an overview of the final rule.
Good morning. John McGinnis, Doc Director. Slide 2, please. There's a list of 8 policies here. These are the major policies. We restructured the APCs for the first time since they were introduced in terms of an overall major restructuring comprehensively throughout all the APCs. We expanded the comprehensive APCs to 9 or 10 new ones. There were a few additions to existing packaging policies. We revised the device pass-through process to make it more consistent with the inpatient new tech add-on process. It was a factor adjustment based on a lab packaging estimate that was an overestimate. Drugs, biologicals, and biosimilars really was the same policy as before, and there were some 2 midnight policy changes. Next slide, please. So the kind of my mantra, if you understand this, then you understand our policies. If you don't understand this, then the policies remain unclear. Next slide. So the APC revisions, if you've read the rule, the proposed rule, and the final rule, and you are interested in what APCs the codes are assigned to, then you know about this. The 9 areas are the primary areas where we did our restructuring. And the net result of this was a significant consolidation and a reduction in the granularity, really to have larger groupings to make it more consistent with the prospective payment system and less like a per code HCPCS level payment fee schedule. Next slide, please. Comprehensive APCs, this is the list of the ones that we added. Probably the most significant of these is the comprehensive APC for observation services. The basic rules governing observation haven't changed, minimum of 8 hours, not associated with a surgery. Or if it is, it's packaged, but at least 8 hours. And then all the ancillaries, diagnostic tests, drugs, et cetera, are packaged, and there's one payment. Next slide. So there were some additions to some of the existing packaging policies in 2015, and there's going to be a presentation, I believe, on an ancillary service that was packaged. But we did some packaging of some additional APCs, minor procedures. So now all the minor procedure APCs, levels 1 through 4, have conditionally packaged items and services, and the remaining pathology APCs, those procedures were packaged. Drugs and surgical supplies, we went through the list. We think we got them all, but we never really quite get them all. But for 2016, there were 4 that we saw that are part of a surgical procedure, so they'll be packaged. One of those is still on pass-through, so that one will be packaged once it comes off pass-through. Next slide. The device pass-through process, so to just simplify things and to make sure that we don't get the old stuff recycled, we require that the applications be new, and we define that as within 3 years of FDA approval. We still evaluate applications on a quarterly basis, but we will put the applications in the proposed rule. The quarterly application process does allow us to preliminarily approve and begin pass-through status on a quarterly basis, but every application will be in the proposed rule, out for 60 days of comment, and then a final decision will be made in the final rule. And the rule will be the first rule that is available after the application is received. Next slide. Other policies, so chronic care management was a physician fee schedule policy, and what we did last year was just explain the requirement. There are a lot of requirements to build those codes, so we explain those in the preamble in the context of providing that service in the OPPS. The conversion factor adjustment was an adjustment that we made to correct an overestimate for lab packaging policy and how much money had to be shifted from the CLFS to the OPPS back in 2014. Next slide. Some other policies, so really the same payment for drugs and biologicals, ASP plus 6. A biosimilar product was introduced, and that policy was explained primarily in the physician fee schedule rule, but there is payment for that biosimilar in the OPPS, and it's the average sales price plus of the reference product ASP. And finally, I won't go into this, but there were changes to an inpatient policy, the two-midnight policy, which is the policy that governs when a patient is an inpatient. So that concludes my presentation.
Thank you, Dr. Thank you, Dr. McGinnis. Are there any questions for Dr. McGinnis?
If you have any questions, please submit it in the chat box or raise your hand. Thank you.
This is Dr. Pregler. I raised my hand, but is it okay for me to speak?
Go right ahead, Dr. Pregler.
I'd like to ask one question about the presentation. I noticed that phenylephrine and ketorolac were included as drugs that would now be considered surgical supplies. Those are principally administered by perhaps the anesthesiologist for maintenance of blood pressure or for postoperative pain control. Is the intent to incorporate all anesthetic drugs into the surgical supplies?
Well, yeah, John McInnes, Doc Director. So that particular combination is referring to a drug that is used to dilate the pupil and reduce inflammation in cataract surgery. The brand name is Omidria. But there is a policy that we have that is in 42 CFR 419.2b4 and 5, I believe, that packages all anesthesia drugs. So it's kind of a two-part answer. The first part of the answer is that the drug listed there refers to a different drug than you're referring to, but anesthesia drugs are packaged with surgery. That's a long-standing policy.
All right. Thank you for the explanation.
Are there any other questions? Okay. If not, we will move on to the subcommittee reports, and I'm going to go a little out of order. And I'm going to start with the APC, this is Edith Hambrick, APC Group and Status Indicator Assignment Subcommittee report. If Dr. Francis could give us that report, I'd appreciate it.
Okay, I'm on the line here. So the APC Classification Group and Status Indicator Group met prior to this meeting. Our subcommittee participants were myself, Dr. Nolan, and Chris Zimmer. We discussed a stakeholder presentation that's going to happen later this morning on the OPPS packaging policy for low-frequency, non-contact, non-thermal ultrasound therapy, and we looked at data, coding, and clinical groupings. We also discussed the results of the newly packaged services utilization study, which compared costs of certain ancillary services that were separately payable in calendar year 2014 and conditionally packaged in calendar year 2015. That was a prior request from this subcommittee to CMS, and they presented that information to us during our meeting. Our recommendations were that first we deferred recommendations on the above-mentioned stakeholder requests on which there will be a public presentation, and so we will give our recommendations, our insights after having discussed this prior to the meeting, but would wait until after the public presentation today. The subcommittee also recommends that we continue our work for the APC group and SI assignments continue. And finally, we recommended that myself continue to serve as the chair of the APC group and SI subcommittee.
Edith Hambrick here. Thank you, Dr. Francis. Are there any questions from the panel members to Dr. Francis or any other member of the subcommittee? Okay, hearing none. Let's go on to the data subcommittee report from Mr. Schroyer.
Yes, thank you. The committee members who participated were myself, Erica Hardy, Karen Lambert, and Ruth Lundy. And we also had APC, SI subcommittee members, Dr. Flo and Manager, and also CMS staff of Dr. McGinnis, Hambrick, David Rice, and Carol Swartz. We discussed cost changes associated with APCs fluctuating by greater than 10% between the calendar year 2016 OPS final rule and calendar year 2007 OPS panel data. And we also reviewed utilization and cost data for services that were newly packaged in calendar year 2015 and compared data for these services in calendar year 2014. Our recommendations are CMS provide the subcommittee a list of APCs fluctuating significantly in cost prior to each HOP panel meeting, that the work of the data subcommittee continue, and also recommend that I continue serving as subcommittee chair for the August 2016 HOP panel meeting.
Thank you, Mr. Schroyer.
Thank you.
Edith Hambrick here. Are there any questions from panel members for Mr. Schroyer or any other subcommittee members? Okay, thank you. And lastly, we'll have a presentation about the Visits and Observations Subcommittee report if Dr. Rabowski has been able to get on. If not, could one of the other subcommittee members, either Dr. Pregler, Ms. Resnick, or Dr. Thompson, give the subcommittee report?
Well, if nobody's jumping at it, Edith, I'll participate. This is Dr. Pregler.
Thank you very much.
The subcommittee met on, seeing March 10th here. Is that correct? I think it is.
I think so.
Met on March 10th via phone conference and also phone conference. Present were Michael Rabowski, myself, Jonathan Pregler, Wendy Resnick, and Norm Thompson. CMS staff who participated were Edith Hambrick, John McInnes, David Rice, Twy Jackson, and Carol Schwartz. We reviewed the final 2016 OPPS payment policies related to visits and the new comprehensive observation services, CAPCs. The subcommittee discussed currently available 2015 and 2014 frequency and mean cost claims data for visits and for the new comprehensive observation services. We also discussed currently available frequency and distribution claims data for 2015 and 2014 for observation services. We made 3 recommendations. The subcommittee recommended that CMS continue to report clinic and emergency department visit and observation claims data, and if CMS identifies changes in patterns of utilization or cost, bring those issues before the subcommittee in future meetings. Subcommittee recommended that the work of the Visits and Observations Subcommittee continue, and we recommended that Dr. Rabowski remain as our subcommittee chair.
Thank you, Dr. Pregler. This is Edith Hambrick. Are there any questions from panel members to Dr. Pregler or any of the other subcommittee members? Hearing none, we'll move into the presentation part of our agenda. Let me just, since we've had some issues with the phone, I just want to make sure that the first one we had scheduled was from the Medical Device Manufacturers Association. Mr. Beebe, are you on? Okay. I think I heard Ms. Dorsey earlier. Maybe we'll go to the AdvaMed presentation. Are you on, Ms. Dorsey?
Yes, I am.
Okay, well, let's start with your presentation. And for those on the web, it's attachment number 2. And I'll give people like a couple of seconds to get there. It's the AdvaMed presentation, which is now being pictured on the WebEx, okay? All right, Ms. Dorsey, why don't you go ahead?
Great. Thank you, Dr. Hambrick. Once again, AdvaMed appreciates the opportunity to address the advisory panel on hospital outpatient payment and commends the panel on efforts to evaluate and improve hospital outpatient payment and beneficiary access to new technologies. AdvaMed's member companies use medical devices, diagnostic products, and health information systems that are transforming healthcare and range from the largest to the smallest medical technology innovators and companies. And today our comments will address 2 key topics, reconfiguring APCs, and then we have some APC-specific comments. There are several issues related to reconfiguring APCs. We'd like to start with comprehensive APCs. Comprehensive APCs were first used on Medicare claims in calendar year 2015, and the claims data that will be used to generate the 2017 outpatient rates will represent the first full year of claims data that has been used for rate setting since establishment of CAPCs. This presents the first real opportunity to see the impact of these changes on reimbursement for and utilization of these services. AdvaMed previously expressed concerns regarding whether CAPC rates adequately or accurately reflect all the procedures and costs associated with those APCs, especially given the potential for continued expansion of packaged and bundled services. We encourage the panel to recommend that CMS analyze the claims data and report on the impact of the conversion to CAPCs for the 25 CAPCs that went into effect on January 1st, 2015. We also encourage the panel to recommend that CMS monitor and report on the impact of comprehensive APC changes on all affected codes and any potential impact to patient access to services. On the issue of complexity adjustments, CMS has developed a process for identifying and applying complexity adjustments to certain combinations of codes as part of the CAPC policy. CMS has taken steps to refine the complexity criteria and the process for complexity assignment. However, AdvaMed continues to have concerns regarding appropriate application of complexity criteria and the resulting APC assignments for codes within the CAPCs. AdvaMed requests that the panel recommend that CMS monitor and report on the impact of applying complexity criteria on APC assignments for code combinations within the comprehensive APCs. On the issue of device edits, we have previously expressed concern regarding the elimination of device edits. The calendar year 2016 rule finalized a proposal requiring device codes on claims for devices assigned to device-intensive APCs, and AdvaMed supported that decision. However, we do request that the panel recommend that CMS continue to monitor claims to evaluate the need to reinstate all device edits. On the issue of the restructuring APCs, we support CMS's objectives of improving clinical and resource homogeneity, reducing overlap within APC families, and simplifying and improving understanding of APC structure through restructuring and renumbering APCs. However, we're concerned that any restructuring changes achieve CMS's goals while preserving stability and predictability within the payment system. Some of the restructuring proposals may result in wide variations in payment and may produce groupings that are too broad, creating APCs that do not appropriately reflect resource distinctions. We urge the panel to recommend that CMS staff engage with relevant stakeholders to solicit input regarding restructuring of APCs, and urge the panel to recommend that CMS monitor and report on the impact of its restructuring policies. We had a comment regarding skin substitute products in the context of packaging. For calendar year 2016, CMS is continuing packaging for skin substitute products and paying for these products via a lower high-cost APC structure. For calendar year 2016, CMS will consider mean unit cost or per day cost in determining and identifying the appropriate cost threshold. AdvaMed is pleased with CMS's ongoing efforts to establish more accurate high and low cost thresholds for skin products, but has concerns with the impact of these changes in policy on low cost products, especially those used to treat wounds less than 100 square centimeters. Our statement contains 4 recommendations regarding these changes, including monitoring the impact of the high and low cost threshold pricing on the use and availability of skin substitute products, and creating an APC group for the application of low cost skin products for wounds less than 100 square centimeters. Lastly, I will move on to some APC specific comments, the first of which relates to multi-session stereotactic body radiation therapy in APC 5625. Payments for this procedure continue to decrease, with the rates for calendar year 2016 being approximately 11% below the 2015 rates. AdvaMed does not believe that these rates reflect the actual cost of providing these services and is concerned the continued decreases in payment will impair beneficiary access to what could be the most appropriate and safe treatment alternative. We are also concerned about the future impact of these inaccurate rates as CMS continues to expand packaging of services. AdvaMed asked the panel to recommend that CMS continue to work with stakeholders to ensure appropriate payment for multi-session stereotactic body radiation therapy. And lastly, on disposable negative pressure wound therapy, AdvaMed has ongoing concerns that the outpatient claims data for these services may inadequately reflect costs due to coding confusion and poor hospital reporting. In addition, the outpatient claims do not capture the cost differences between traditional NPWT and disposable NPWT. And AdvaMed has concerns that current rates do not cover the cost of disposable NPWT devices and may impair patient access. We are therefore asking the panel to recommend that CMS continue to work with stakeholders to gain better cost data and to guide the appropriate APC assignment for disposable NPWT technologies. AdvaMed appreciates the panel's time and appreciates this opportunity to present our comments.
Thank you, Ms. Dorsey. Are there any questions from the panel for Ms. Dorsey?
So this is Scott Manager.
Scott Manager. Go ahead, Dr. Manager.
Okay. Ms. Dorsey, I'm intrigued by your comments on the stereotactic radiation therapy and your concern that the costs are not being captured. I'm wondering what, if any, evidence you have that costs are missing. Are there some pieces or components that are not being captured in the cost reports? Do you have some providers who have shown their finances and demonstrate they can't provide the service at the cost that reimburse? What's the evidence for this?
Dr. Maneker, thank you for the question. And what I would say is that we definitely have member companies who are involved in this space who have expressed concerns on behalf of the physicians that they deal with who provide these services to patients. And I would be happy to work with those companies to get you additional data to substantiate concerns related to the payment. I think that overall there have been ongoing concerns regarding continuous reductions for these services, and this is further complicated by additional changes affecting the radiation therapy space that went into effect in last year's physician payment rule. So there's definitely been an ongoing concern regarding treatment and payment for these services, and I'd be happy to work with companies to produce a more concrete information for CMS. And there may be some of those members on the call. I'm not certain because I can't tell from the list, but I would encourage them to chime in and raise their hand for the public comment portion of this meeting.
Well, just to be clear, the manufacturers of the equipment are not providing the services. Doctors and hospitals are providing the services.
Oh, I understand that, and I think
that's really the origin of my question, whether there are doctors and hospitals who provided you evidence that these reimbursements don't cover the cost.
Oh, no, and I understood your question. I think what I was trying to convey was that our members received this feedback from their customers who are physicians and hospitals. And so I would be willing to work with them to produce the information that you're seeking and regarding actual hospital and physician impact created by these changes.
Are there any more questions? Go ahead, Dr. Manica.
No, I was just a thank you.
Oh, okay. Are there any more questions from panel members for Ms. Dorsey?
Yeah, this is Mike Schroyer, and that was a great question that was asked, and this came up at the last panel meeting, that we seem to have a lot of manufacturers coming and requesting these type of things, but we never see any data. And it was stated in our last meeting that going forward, that, you know, before somebody comes and asks this type of questions for us to make these recommendations, that they provide data showing where, you know, the reimbursement isn't covering costs. And that data really needs to be coming from the physicians and the hospitals. So I would make a recommendation that we table this until they can come back and show us data supporting their comments.
Okay. Any other? In general, if they, what would be formed as a recommendation, as you've asked, we certainly could do that. But I think Ms. Dorsey has gotten the message that her stakeholders need to bring us some data.
Yes, I have.
Okay. Any other questions from Edith Hambrick again, panel members? If not, I'm going to open it up to the public to make comments. So any other panel member questions or comments about the presentation? If not, are there any members of the public who would like to make a comment? Please raise your hand via the chat as Ms. Boone has indicated, or if you're not on the chat, just speak out. You have any hands raised, Ms. Boone, in the chat?
I only see Dr. Beebe. He's still unable to get in. There's another caller. Give me 1 second. Michael, I have your hand raised. I've unmuted your line. Do you have a question?
I just wanted to make sure that you could hear me because I haven't been able to call in.
Who's the presenter?
DMA. Who was that?
Oh, this is Mr. Beebe?
No, he's not.
Who is this?
Michael
No,
Beebe.
this is another Michael.
Another Michael. Dr. Rabowski.
No,
this is Dr. Rabowski. Can you hear me?
Now we can hear you. Thank you, Dr. Rabowski.
Thank you. That was my question.
I have Ann Hubbard on the line who would like to ask a question.
Okay, go ahead, Ms.
Ann, your line is unmuted.
Great, thank you. This is Ann Hubbard with ASTRO, the American Society for Radiation Oncology. I just wanted to chime in on that last conversation regarding APC 5626. We are looking to put forward some data and to provide this group with some analysis regarding our continued concerns about the decline in reimbursement for that particular APC, as well as several others. And you'll see the comments that we submitted along with our friends at ACR, AAPM, and ABS, that's a project that we're going to work on and expect to deliver to this group within the next several months.
Thank you, Ms. Hubbard. Are there any other Edith Hambrick, are there any other comments from the public on this presentation?
No, I show no other hands raised at this time or no comments in the chat.
Thank you. Are there any, this is for the panel members, are there any recommendations with regard to this presentation? Okay, thank you very much. Let's see if Mr. Michael Beebe is online.
No, he hasn't dialed in yet. This is the moderator. I'm going to call him back and conference him in through my line. So if you can give me a few minutes, I'll give him a call.
Shall we go on with the agenda, and then when you get him, we'll go on. Okay, we'll go on with the agenda, and when you get him, then we'll put him in queue. The next speaker after that, thank you, Ms. Dorsey. The next speaker after that I have is Dr. Peter Oreo and Ms. Wendy Smith. It's attachment number 3. Are you with us, Dr. Oreo and Ms. Smith?
Good morning. This is Peter Oreo.
Are you with us, Ms. Smith?
She was there for backup.
Okay, so why don't you go ahead, Dr. Oreo, and if Ms. Smith joins us, she can make her comment.
Okay, well, good morning. Again, my name is Peter Oreo, and I want to thank you, Dr. Hambrick, and the members of the advisory panel for the opportunity to present the views of the American Brachytherapy Society this morning, as we feel there was an error in the calculation of the geometric mean cost of high-dose rate brachytherapy codes in APC 5624, which is now the level 4 radiation therapy codes. Throughout this presentation, I hope to shed light on what may have happened. Can I have the next slide, please? PAB, ABS, ACR, AAAPM, and ASTRA have previously submitted comment letters on APC 5624, but today I would like to specifically discuss the impacted CPT codes Quad 70, Quad 71, Quad 72, which capture the work associated with remote afterloading for HDI brachytherapy services. Next slide, please. Now, the affected APC 5624 is comprised of 7 different treatment codes, but today I'm going to focus on Quad 70, Quad 71, and Quad 72, the high-dose rate brachytherapy codes within this APC. Next slide, please. The issue is beginning this year, 77300, which is the basic dosimetry calculation, has been bundled into the affected codes Quad 70, 1, and 2, which are based on predecessor codes 7785, 7786, and 7787. But the issue is CPT 77300 is on the bypass list. Since 77300 is on the bypass list, it is stripped from the claims data upon receipt. Because of the code's inclusion on the bypass list, we believe that CMS was unable to include the cost associated with the bypass code 77300 when they were calculating the geometric mean cost of HDI brachytherapy codes in this APC. This becomes inequitable as it remains separately payable for some claims, but not calculated into this APC's bundle. Next slide, please. So although the payments for Quad 70, Quad 71, and Quad 72 have decreased 4.6% from 2015 to 2016, we are concerned that this decrease is actually much greater, as the current payment methodology did not factor in the loss of payments from CPT 77300, which is currently valued at $107 per charge. Next slide, please. So Christopher Hogan completed a data analysis for this APC and based his calculation on predecessor HDR codes. As a result of the data analysis showing the exclusion of 77300 from the calculations of this APC family, we're recommending that the HDR brachytherapy codes be treated as a composite code with 77300 when claimed together. Now, we're not requesting a new composite APC, but would rather ask CMS to consider calculating the geometric mean cost of the composite codes and therefore recalculate the APC payment. This methodology allows CMS to treat the combination of one HDF brachytherapy treatment unit plus one unit of 77300 as one payable code and to process it as a single procedure claim. This methodology provides a solution which allows 77300's cost to be included in the payments of APC 5641 brachytherapy, which is now APC 5642 level 4 radiation therapy. So for Christopher Hogan's analysis, if this methodology were used, it would result in approximately a $75 increase in reimbursement, which would be less than the $107, which is currently reimbursed when 77300 is reported separately. Next slide, please. So we are recommending that CMS consider recalculating the geometric mean cost of APC 5624. In doing so, we suggest using the composite code methodology to include the cost of CPT 77300 basic dosimetry calculation in the HDI brachytherapy codes Quad 70, Quad 71, and Quad 72. Slide, please. Our rationale is based on our belief that CMS made an error when calculating the rates for Quad 70, Quad 71, and Quad 72, secondary to the very unique situation whereby a bypass code, which still remains separately payable elsewhere, was bundled into the specific APC and was likely not accounted for. So it would be wrong to continue to calculate the APC without capture of the 77300, and to continuing to adopt this methodology would base bundles on only a portion of the predecessor codes. This methodology is currently established to base reimbursement on only a portion of the predecessor codes is simply not in line with the efforts of the ROC and CMS under the HOPS. Next slide, please. The potential consequence of CMS waiting for 2 years of claims data to revalue these codes is that inaccurate payments and reductions to brachytherapy reimbursement will ensue. As 77300 is a bypass code, the current methodology without resolution would result in the cost never being captured in 2018 or beyond unless CMS uses the composite code methodology to capture the cost of basic dosimetry calculations, which are now included in the HDR brachytherapy codes Quad 70, Quad 71, and Quad 72. Inaccurate HOPS reimbursements may result in a reduction in the utilization of HDR brachytherapy in the hospital outpatient setting. Thank you for listening. That now concludes my presentation.
Thank you, Dr. Oreo. We'll have a comment by Dr. McGinnis first.
This is a recap of a comment that we received to the proposed rule, and I think it reflects a misunderstanding of the OPPS methodology. Really what we have here, this doesn't have anything to do with the bypass list. These are new codes, and what CPT has been doing with a lot of codes is bundling codes together, and so they did it with these codes. But in the OPPS, unlike with the physician fee schedule where they modify codes that are more than an editorial change, they frequently change the RVUs because that's how the physician fee schedule works. In the OPPS, we don't model new codes. What we do with new codes is we place them in the most appropriate APC based on the clinical characteristics of the procedure and the resource costs, and then we wait until the data is updated because we update, unlike the physician fee schedule where there's a one-time evaluation of the RVUs and it's put into that fee schedule, and then it's not evaluated until the code changes or it's put on the misvalued codes list. Every year we update the OPPS claims data, and so this data will be updated based on the new codes in 2016 for 2018. Until then, the data that supports payment for these are the data from both the old codes and the other codes that are in the what was formerly the brachytherapy APC that we retitled Level 4 radiation therapy. But this is just simply the OPPS methodology that we use for every new code. There's no difference here between the way we do it with these codes and the way we do it with every code. We don't model. We don't like add. Sort of the analogy was made in the mention of the RUC. We don't kind of add RVUs and use that kind of thing to adjust that. We wait for the data, and the data is updated on an annual basis.
Thank you, Dr. McGinnis. Are there any questions? Edith Hambrick here. Are there any questions from the panel to the speaker, Dr. Oreo?
Yes, this is Dr. Thompson. Can you hear me?
Yes, we can. Go ahead, Dr. Thompson.
Thank you. A quick question to Dr. Oreo. Would the proposed revaluation change the APC assignment for these 4 codes?
It would not change the APC refinement. In fact, we're not even asking for a new APC. I guess my understanding of the situation is that since 77300 was on the bypass list, and then usually that's sort of scrubbed early in the programming. It's our thought that it wasn't included when the valuation of quad 701 and 2 was being assigned. And I guess the concern becomes if we wait, if it claims data, it might not reflect the 77300 because it wasn't put in initially. In our understanding. And this is 77300 is, you're able to bill this separately with other codes outside of the HDR codes we were talking about. And I think that's where the confusion arises. We just feel like it wasn't considered just because of such a low number of claims, and the fact that it's probably early from the data sets during the programming that they really noticed, and as such they could not be valued correctly or be included.
Thank you, Dr. Orio. Do you have any evidence that sites are discontinuing or rationing services on the basis of this proposed reimbursement change?
I mean, this is when the CAB's comment letter, which came, I think, on August 26th, Chris Hogan has shown his methodology of how he was looking under these the composite codes, and the feeling that obviously when we're doing this wasn't, these were sort of these placeholder codes, but now they've been assigned, that it appeared that 77300 was not part of the calculation. And I'd have to kind of point you towards that methodology to make that more clear.
Okay. A more detailed question. Has hospitals and other providers report their cost data out for the 4 quad 7 0 through 3 codes? I presume they will be capturing the cost data for the dosimetry code. Is that a correct assumption?
Well, I guess that's a hope, but it puts a lot of administrative burden on the hospital, although I do agree, when we start to bundle these payments and we're looking for sort of 2 years of data before we go back and take a peek, it's important that everything that would have been included is included. And my fear, though, is it's not going to be just because of the administrative burdens and, not clearly understanding the instructions to possibly do so without, specific, direction by CMS and others.
Thank you, sir. I have no additional questions.
This is Edith Hamrick again. Any other questions from panel members?
Edith, it's Scott. I have a observation for other members of the panel to just consider. If you take a look at the range of codes that are in APC 5624, there's a range of payments as low as $400 and as high as $950. So even a $100 adjustment is still going to suggest these codes are assigned to the proper APC, and the process is functioning properly, as Dr. McGinnis suggests.
What page? Oh, it's on in my paper page. I'm not sure what it is online. I don't know if it's page 148 for the panel members. What page do you have for that? 143, according to Ms. Baldo, Captain Baldo, administration. So 5624 is on page 143 for those that want to look at from the website. Are there any other observations, questions from the panel members before I throw it open to the public to ask questions or make comments? Hearing none, any member of the public wish to make a comment or ask a question?
I have a question from Ann Hubbard. I'll unmute her line.
Thanks.
You're welcome. Ann, your line is unmuted.
Hi, this is Ann Hubbard again from Astro. I just wanted to register our support for the ABS recommendation that there be some recalculation of the geometric mean cost for the HDR breaking codes to include the dose calculation 77300.
Thank you, Ms. Hubbard.
Thank you.
Are there any more comments or questions from the public? So this is Edith Hamrick. I'll throw it back to the panel. Do you have any recommendations that you would like to make with respect to this presentation?
Yes, this is Dr. Thompson.
Go ahead, Dr. Thompson.
One more question for CMS. In establishing the proposed geometric mean calculations, is the use of predecessor codes to be bundled together with the proposed code a rational approach to calculating proposed APC payments?
We do not do that. If we were to do that for these codes, we would have to do that for every code in the past. That has been done, and what we discovered is that often the modeled costs were significantly different than the ultimate actual cost that we got from the claims data. So in the few, we have never had this, taken this approach as a general policy. But in a few situations where we have adopted it, it has not served us. So what we do with new codes is we place them in the most appropriate APC, and then when the data comes in, it will be, the new data, that will be part of the geometric mean calculation. In this case, it's not going to change the assignment for these codes because, as Dr. Maneker pointed out, the range for level 4 radiation therapy, the next jump up would be to the APC that has the proton beam, and then the next level down is IMRT. So we've kept everything pretty much the same, but that is how we do it in the OPPS.
Thank you, Dr. McGinnis. You
Thank
had a follow-up?
No, Dr. Hamrick. Dr. Thompson signing off. I have no additional comment.
Okay. Edith Hamrick again. Are there any recommendations with respect to this presentation from the panel? Okay, hearing none. Let's go back. I understand Mr. Beebe is available from the Medical Device Manufacturers Association. It's attachment 1. Are you there, Mr. Beebe?
I certainly hope so, Edith. Can you hear me?
Oh, very good, Mr. Beebe. Welcome.
Boy, the build-up for this was like the new Star Wars or something. I hope I'm going to meet everybody's expectation.
Yeah, you better try to do that, sir, because we've been waiting for you.
Good. Well, thank you. I apologize for the technical problems. I'm presenting on behalf of the Medical Device Manufacturers Association, MDMA. MDMA represents hundreds of medical device companies, and their mission is to ensure that patients have access to the latest advances in medical technology, most of which are developed by small, research-driven medical device companies. So for calendar year 2016, CMS continued to expand use of the APC payment policy methodology implemented in 2015, created 9 new CAPC. Changes, along with changes implemented for 2015, mean that CMS has developed 34 CAPCs, representing a major overhaul of the outpatient payments system. MDMA is concerned that the changes are happening so quickly as there's not been time or data available to understand the effect of these significant changes on access to care and appropriate utilization of innovative technologies. Beneficiaries' access to life-saving technologies depends on appropriate implementation of complicated rate-setting calculations and accurate bundling policies. It's essential that CMS continue to proceed cautiously in its continued packaging policy expansion. And in order to ensure that OPPS continues to provide Medicare beneficiaries access to appropriate innovative care, we asked the HOP panel to consider these following 5 recommendations. 1, CMS should evaluate the impact of its most recent expansions of packaging on access to care before implementing any new packaging proposals. And we've made this recommendation in the past, and we believe that the HOP panel is open to acquiring the additional data. CMS recently finalized the expansion of packaging policies to involve complex interrelated changes to rate-setting calculations. Each year's proposals build on prior changes to the OPPS, often before the effect of those earlier changes on access to care can be measured. Piling change upon change without understanding how the changes impact beneficiaries or providers is not appropriate. As we've suggested in past comment letters and statements to this panel in the past, more time is needed to analyze hospital responses to these new incentives and effect of the changes on beneficiary access to care. And I note that one of the earlier presenters noted that the administrative burden on hospitals to be sure that they provide all the necessary codes to document the cost in each one of these new CAPCs is highly critical, so to make sure that we're capturing it correctly, and it's unclear whether that's happening at this point. Recognizing the importance of evaluating data on newly bundled services and the impact of the bundling has had on these services, in the spring of 15 meeting, the HOP panel requested that CMS provide utilization data on newly packaged services to the data subcommittee for review at its next meeting. And so we very much appreciate this recommendation and would like to see that continue. So again, we ask the HOP panel to recommend that CMS report on the effects of its packaging proposals on access to items and services that no longer are separately reimbursed. We're concerned that packaging of procedures has the potential to create perverse incentives. For example, radiofrequency ablation of spinal metastases frequently required the installation of bone cement to support the vertebral body. However, packaging these procedures, the installation of the cement and the RF ablation, puts the hospital a financial disincentive when procedures are performed together. At the same time, not doing them together may put the patient at risk. No hospital or physician should be faced with a choice between financial well-being and patient well-being. In addition, CMS's analysis of such situations is needed before the program of comprehensive APCs is extended. Number two, CMS should allow adequate data to be collected to better understand the impact of packaging changes and to verify that the proposed rates accurately reflect hospital costs. For calendar year 2016, in addition to expanding packaging, CMS finalizes proposal with modifications to restructure 9 clinical APC families based on several principles. One, improve clinical and resource homogeneity, reduce resource overlap in long-standing APCs, and improve understandability of the OPPS APC structure. By finalizing this proposal, CMS eliminated more than 80 APCs. In some cases, the consolidation appeared to be reasonable, and MDMA generally supported such consolidation. In other cases, by contrast, such dramatic consolidation has the potential to exacerbate payment inequalities and inaccuracies. In those instances, the MDMA did not support such consolidation. For example, MDMA was concerned about the resulting drastic payment reductions for some procedures in those APCs, specifically the proposed reassignment of codes 31295 and 31296 within the restructured airway endoscopy APCs. MDMA provided comments on the proposed rule asking CMS to assign those codes to level 5 APC. We thank CMS for taking the comments into consideration when restructuring APCs by reassigning the codes 31295 and 31296 to APC 5155 in the 2016 OPPS final rule. Consolidation drastically affects payment rates for other services in the final rule, however, and further consolidation would raise concerns about inadequate payment rates. Therefore, MDMA again recommends CMS move more slowly with further consideration of clinical APCs until the agency has more information on the impact that consolidation and bundling has on patient access to outpatient services.
You have a couple of minutes. Mr. Beebe, you have a couple of minutes left.
Thank you, Edith. Thank you. It's hard to see the clock on this end.
Well, I'm going to tell you on my clock you got a couple of minutes left, sir.
All right. Very well. Thank you. So we're concerned that CMS that they should use the HOP panel and its public meetings as an opportunity to gather additional evidence on potential expansion of packaging policies before deciding whether to extend the packaging. 3, CMS should not package payments for newly created codes for at least 3 years. We're concerned, for example, with the bundling of newly created Category 3 codes 0406T, 0407T in the existing APCs before additional data can be collected on those codes. 4, CMS should continue to require complete and correct coding for package services to ensure that the agency has accurate data for use in setting payment rates. And number 5, finally, CMS should remain as transparent as possible about the data used to set payment rates. We ask the HOP panel to recommend that CMS remain as transparent as possible about the data it uses to set APC payment rates. So, in conclusion, MDMA is encouraged by the panel's willingness to address important issues in the OPPS, and we look forward to working with CMS in the future to continue to make improvements in the system. Thank you very much.
Thank you, Mr. Beebe. Are there any questions from the panel members for Mr. Beebe? Hearing none, are there any hands raised, Ms. Boone, or are there any questions from the public or comments for Mr. Beebe?
No, I don't see any questions or comments and no hands raised. Not at this time. Thank you.
Thank you. Are there any recommendations from the panel members with respect to this presentation?
This is Michael Rabowski. Just a comment. I think following up on an earlier comment that was made this morning, when presentations are made with an example of the cost to the hospital of a procedure like the cement in the spine before the radiotherapy, it actually, I think, would be helpful to me and panel members to know really what the real costs are that is being discussed. I think a comment was made, doctors shouldn't choose between financial well-being and the well-being of their patients. It would help me in looking at this to know really what the finances actually are to the hospital so we can evaluate whether CMS is providing an adequate payment.
Thank you. Any other comment from a panel member or a question? I did see a hand raised from Ms. Wrinkle. Ms. Wrinkle, did you have a comment?
Because she's not dialed in correctly, we're unable to unmute her line. So I can't unmute her. I apologize.
Thank you. Thank you, Ms. Boone.
Thank you.
One suggestion I think that Ms. Boone had before, that if you send it in via chat, Ms. Wrinkle, maybe we could deal with it and come back to it. Okay, hopefully you heard that part. All right, are there any recommendations with respect to this presentation from the panel? If not, we'll move on to the next presentation. It's going to be about low-frequency, non-contact, non-thermal ultrasound therapy. It is presentation attachment 4. I believe that Dr. Gibbons and Mr. Gregg, you want the PowerPoint presentation. Is that correct? To be displayed? Yeah. Okay, great. First, though, we'll have an overview from Captain Marjorie Baldo, who's going to give us an overview on the topic, followed by your discussion.
Hi, everyone. This is Captain Marjorie Baldo, CMS staff in the Division of Outpatient Care. This next topic relates to OPPS status indicator assignment for CPT code 97610, which is a code associated with the missed ultrasound therapy. Before Liqua begins the presentation, let me provide some background information on CPT code 97610. The code was established by the CPT editorial panel effective January 1, 2014. It describes a non-contact, low-frequency ultrasound therapy for acute and chronic wounds. Prior to 2014, the code was described by Category 3 CPT code, specifically 0183T, which was effective January 1, 2008. The code was deleted on December 31, 2013, and replaced with Category 1 CPT code 97610, effective January 1, 2014. For the 2016 update, we revised the OPPS status indicator from T to Q1, effective January 1, 2016, to indicate that the service is conditionally packaged but separately payable when not billed on the same date of service as a HCFIX code assigned to OPPS status indicator S, T, or V. Prior to implementing this change, we published our proposal in the 2016 OPPS and ASC proposed rule. We received some comments related to this proposal, which are similar to ALIQUA's comments. We made the change to the status indicator for CPT code 97610 as a result of our 2015 finalized policy to conditionally package ancillary services in the OPPS. Conditional packaging means that when this service is provided with other services, it is packaged. However, when it is provided on its own, it is paid separately. This ancillary services packaging policy applies to minor services performed ancillary to other primary hospital outpatient services. We determined that the service described by CPT code 97610 is frequently performed as an ancillary service to other primary services, such as wound debridement. As a result, for the 2016 update, we decided to conditionally package CPT code 97610 in the OPPS under 42 Code of Federal Regulations, Section 419.2b7. For the 2017 OPPS update, based on the latest hospital outpatient claims data that we have, we believe we should continue to assign CPT code 97610 to status indicator Q1. The latest hospital outpatient claims data, which is based on claims submitted between January 1, 2015 through September 30, 2015 and processed through September 30, 2015, is posted on the CMS website. The file labeled 2 times listing was included with the hot panel documents for this meeting. For the hot panel members, for your reference, page 5 of your 2 times printout shows the latest claims data that we have for CPT code 97610. The code is listed as the 4th asterisk on page 5. In the row for 97610, under the total claims column, there are 10,964 total claims, but only 6,122 single claims, which shows that the service described by CPT code 97610 is performed with other hospital outpatient services almost half of the time. In summary, based on this data, we believe there is no reason to change the packaging status for CPT code 97610 and that we should continue to conditionally package the code and assign it to status indicator Q1 for the 2017 OPPS update. That concludes the background information on CPT code 97610.
Thank you, Captain Baldo. Are there any questions from the panel members for Captain Baldo? Okay, if not, we will hear from Dr. Gibbons and Mr. Gregg. Attachment 4A, I believe, is a Word document that explains their position, and we're going to look at the PowerPoint presentation, which is now displayed on the WebEx. Go ahead, please.
Good morning. Thank you for allowing me to present today. My name is Dr. Gary Gibbons, and I'm here today to talk about my experience with MIST therapy system. Next slide. I've been a practicing vascular surgeon specializing in wound care for more than 40 years. I'm the medical director for a large wound center outside of Boston and also a professor of surgery. As summarized on this slide, I'm here to request CMS to reassign the T-status indicator to the CPT code describing MIST therapy 97610 in recognition of the independent nature of the procedure. I'll begin with a general overview of what MIST therapy procedure is and what it is not. MIST therapy involves non-contact, low-frequency, low-intensity ultrasound and LFU being delivered through a saline mist to the wound bed. Importantly, this does not involve removing any unhealthy or dead necrotic tissue. is procedurally and therapeutically distinct from debridement, high-intensity ultrasound, and contact ultrasound. The ultrasound energy stimulates cells in the wound bed to accelerate healing. MIST is the only non-contact ultrasound device cleared by the FDA with an indication to promote wound healing. CPT code 97610 descriptor is specific to MIST therapy and includes not only NLFU therapy itself, but also wound assessment and instructions for ongoing care. Next slide. As you can see here, the MIST therapy requires a unique FDA-cleared equipment to generate and deliver low-frequency ultrasound energy to the wound bed. Next slide. MIST therapy is a primary independent procedure that should not be considered an ancillary procedure under the OPS packaging policy. The AMA Association decided this in June of 2014. I was a presenter to them at their meeting in February that led to this decision. In June 2014, CPT assistant the AMA described MIST therapy as standalone service, specifying a procedure that includes careful wound assessment, measurement, photography before cleansing the wound and the surrounding tissue. They may also confirm that debridement and MIST therapy represent different interventions using different medical equipment with different clinical objectives. On this basis, it would be inappropriate to package NLFU therapy with a debridement procedure. The AMA's explanation of NLFU therapy procedure is critical to the CMS packaging decision, since CMS relies in part on coding guidance to determine if a service is ancillary to another procedure. In this case, the clear answer to that question is no. Next slide, please. So this slide provides an overview of the beneficial effects that result from MIST therapy. There are numerous published studies, a meta-analysis, 8 randomized controlled trials. I was fortunate to be a principal investigator for the non-contact low-frequency ultrasound randomized controlled trial on venous leg ulcers published in January 2015 in Ostomy Wound Management. Our patient population included 112 subjects with non-healing venous ulcers, 83% of whom presented with multiple comorbidities that inhibit wound healing. Approximately 1 in 3 of these patients were diabetic, and 56% of these wounds were recurrent with a median duration of 10.3 months. The patients were randomly assigned, and one group that we treated just standard care, and the next receiving NLFU. The findings were significant. 61.6% treated with NLFU, reduction in wound size versus 45%. Strikingly, the pain scores decreased from 3 to 0.6 in the NLFU. While standard wound care, next slide, please. While standard wound care continues to be applied during NLFU therapy, such as debridement, this procedure is independent of any element to the standard of care. NLFU therapy is painless, and the MIST therapy device does not come into contact with the wound. It has also been used in deep tissue injuries to increase blood flow and heal deep tissue injury from within.
Eric Gregg, and I would like to go to the next slide, please.
Hey, Mr. Gregg, you have a couple of minutes to continue the presentation and wrap it up. So,
thank you. Quick here. So These slides just provide an overview of the written comments that specify that missed therapy does not meet the Medicare OPS criteria to be considered ancillary. As we just heard from Dr. Gibbons, missed therapy is an independent clinical procedure that's not typically supportive, dependent, or adjunctive to another procedure, and that's according to both current practice and the AMA. While the presentation from CMS stated that missed therapy is occasionally provided with another therapy, just because two therapies are provided at the same time does not make one ancillary to the other. I think that's reflected in the CMS guidance. In addition, the geometric mean cost for the procedure and the relevant APC exceeds the cost packaging threshold that CMS set in the 2015 OPS rule. And data shows that there are a significant number of times that missed therapy is provided alone and not with another procedure. Next slide. And we can just go to the next slide, which really summarizes that the AMA CPT description for 97610 supports the primary nature of the procedure, and the practitioner time devoted to missed therapy indicates that independent procedure. All considerations under the CMS packaging policies support reversal of the 2016 status indicator assignment of Q1 and the return to the status indicator assignment of T for CPT code 97610. Thank you. That concludes.
Thank you, Mr. Gregg. Dr. McGinnis?
Yeah, I just want to add a little bit to what Marjorie had said in her introduction, just to provide a little bit of context. So in 2015, we adopted a policy to package ancillary devices and items and procedures and services in the OPPS. Really, this had been a policy, this was an existing policy. It was just one that was, for some reason, not fully implemented. So we implemented that 21 or 22 APCs at the time with between 500 and 1,000 ancillary services. And so that was in 2015, and then in 2016, there were about 70 services conditionally packaged as ancillary services, and the missed therapy was one of them. I guess the couple of points that I think would be important is that there's a difference between our ancillary packaging policy and bundling of codes that CPT would do. If there's a code that is included in another code, then that would be the subject of some type of change that CPT would implement or an NCCI edit. So, we recognize that this is a separate code as are all the other codes assigned on the Q1, the conditionally packaged status indicator. But with wound care in particular, there are a lot of different types of things that the patient has. Debridement, there can be missed therapy, there's skin substitute applications, there's negative pressure. There's a whole variety of different different types of treatments, and so the packaging really is looking at the episode of care, and in this context, the missed therapy is a minor ancillary service that accompanies other wound treatments. One of the presenters referred to a threshold of $100 that applied to the 2015 policy. I want to explain that it's not a threshold. We explained this in the rule multiple times. What we did with the original selection of all of the APCs to which we were going to apply this policy is we said that as an initial selection criteria, we would limit our initial list in 2015 to only APCs that were assigned to, only codes that were assigned to APCs with a geometric mean cost of $100 or less. This procedure, even in the panel data, has a geometric mean cost of, I think, $80-some. But just to be clear, we have added other ancillary services to the ancillary services conditionally packaged list that have been over the $100 mark because that's not a threshold. It was only a criteria that we used to make the initial selection just because we wanted to have some limit on our initial policy. The other thing that I think is important, and I think the panel probably understands this, is that to the extent that this procedure is a standalone procedure that is applied to the patient by itself without other services, conditionally packaging pays separately for such services. So if a patient comes into the hospital and only has missed therapy, then they get paid according to the APC assignment, and that's a separate payment because that's the way conditional packaging works. The packaging only works if there's a procedure with status indicator ST or V on the claim. Then this missed treatment would be packaged into that. So those are my comments.
Thank you, Dr. McGinnis. Are there any questions from the panel for the presenters? Are there any questions from Edith Hambrick again? Are there any questions from the public for the presenters or comments with respect to the presentation?
I don't see any hand raised or any comments in the chat box at this time. Thank you.
Thank you, Ms. Boone. Are there any recommendations from the panel members with respect to this presentation? Okay, hearing none. Thank you, Dr. Gibbons and Mr. Gregg. And this is Grieg. Is it Grieg or Gregg?
Greg, thank you.
Greg, okay, thank you very much. Our next presentation, which is a letter, is found at attachment 5. It is from the American College of Radiology, American Society of Radiation Oncology, the American Brachytherapy Society, and the American Association of Physicists in Medicine. And it's I think about a 5-page letter. If you go to page 2, they have some general comments about the comprehensive APC methodology, in which they feel that the methodology does not adequately capture all the charges. That's on page 3. And they also ask for transparency in working, CMS to have transparency in working with stakeholders to develop comprehensive APCs. On page 4, they make similar comments about 77300 and the high-dose brachytherapy services. At the bottom of page 4, they talk about single-session craniostereotactic radiosurgery. On page 5, they go back to the stereotactic body radiation therapy, for which we had a presentation that was part of a presentation earlier. And lastly, they ask stakeholders, they ask that the CMS and stakeholders work together to, appropriately assign 77301 to a higher valued APC. So those are their comments. Are there any, obviously it's a comment letter, is there any discussion by panel members surrounding this letter, after which I'll open it up to the public to make comments? But panel members first, do you have any discussion that you would like to have surrounding the letter? Okay, hearing none at this time, let me open it up to the public to see if anyone has any comments, either through the chat, raising your hand in the chat, or by speaking.
This is Kim. I think I have a question from, it looks like Kathy Give me 1 second to find her question.
Okay, thank you.
You're welcome. Kathy, I'm not sure I'm understanding your question. Can you retype your question?
Can you say your question?
Okay, give me a second, Kathy. Let me see if I can unmute your line. Your line is unmuted, Kathy. Can you hear me?
I can. Thank you, Kim.
Okay, you're welcome. Thank you.
Hi, Dr. Hambrick. This is Kathy Austin, chair of the PRT. And we have a question regarding the HR, if we could possibly go back. Is that okay?
The high dose rate, you mean?
Yes, ma'am.
Okay. The previous presentation, let's see. Which one was that? Number 3, is it? Let's see. The one that was, number 3 from Dr. Oreo and Wendy Smith, that one, the American Brachytherapy Association, that one?
Yes, ma'am.
Okay, so everybody on the line, attachment 3, the presentation from the American Brachytherapy Association. Go ahead, please.
Okay, I'm going to turn this over to Mr. John Settlemeyer.
Hey, good morning, Mr. Settlemeyer.
Hey, Dr. Hambrick, how are you?
Okay, how you doing?
I'm good. We've been trying to get in for a long time, and I apologize that we're going backwards here, but we had a lot of difficulty trying to raise our hand and make comments. But so I just want to make a historical comment related to what Dr. McGinnis was describing about new codes. And, you know, while we do not disagree with what he stated about the placement of new CPT codes, there is historical precedent when CPT actually just merges codes together, where the agency has agreed to move the quote new CPT code to a more appropriate APC earlier than the 2 years. So I mean, if Commander Baldo could maybe confirm the coding of what Dr. Oreo was asking for, so if those new Quad 7 codes, if they represent the old 7778X codes plus 77300, then if it's simply taking those old codes and replacing it with one new CPT code, then there is historical precedence in the like when CPT first created the CPT of the abdomen and the CPT of the pelvis and merged those together into one CPT code. The Provider Roundtable did present a presentation on that many, many years ago, and the agency did agree to revalue based on the history. So we just wanted to raise that comment.
Okay. Thank you, Mr. Settlemeyer.
Thank you.
Now that the PRT is in, were there any other subjects that you wanted to raise a comment about? Okay, hearing none. Let's circle back to the panel first to see if there are any recommendations that anyone wants to make on all of the topics that we've discussed this morning. Okay, hearing none, what we will need to do is approve all of the subcommittee reports, which I'm going to take in order just so we can be complete. But I'll just read off the subcommittee name and then ask for an endorsement to accept the subcommittee report. And then I'll just, all those in favor. So that's how we're going to do that. So let's start with the Visits and Observations Subcommittee report. Do the panel members agree to accept the report for the record, or are there any changes that anyone would like to make to that report? Hearing none, all those in favor of accepting the Visits and Observations Subcommittee report, please indicate by saying aye.
Aye.
Aye. Any opposed? Any abstentions? Let's move on to the Data Subcommittee report. You had 3 recommendations. Do the panel members wish to accept the report as presented? All those in favor say aye.
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 Opposed? Any opposed? Any abstentions? Last but not least, the Ambulatory Payment Classification Group and Status Indicator Subcommittee report. Is the panel in favor of accepting the report as presented? All those in favor say aye.
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 All those opposed? Any abstentions? Okay. It's going to take about, yeah, we do. All right, this is Edith Hambrick. Since we did not have any other recommendations from the panel with respect to the presentations, and the panel members previously had the draft copies of the subcommittee reports, which did not change, and we just voted to accept those without change. Those would be the recommendations. Oh, please hang up. Oh, good. Those would be the recommendations.